right? So I said, a novice nurse has attended staff education. A novice nurse has attended staff education program on cardiopharmacology. The novice nurse will match which medication with the known side effect. All options must be used. You have a bunch of medication. It's a group of medications on the left side. On the right side, there's common side effects. At least if you know one of them for each group of medication, then you'll be fine, right? So what do you think? The first medication, right? The key is to look at the last name. That is pharmacology. That's the only way you can master your pharmacology. They make new medications all the time. And so they call them class of medication. This is the class of medication. I'm giving you a clue. That's the class. This one too is the class. This is also the class. This is also the class. This one, his class doesn't have classic name, but I've basically answered the questions for you. And so help me out, fill the form. The novice nurse is waiting for you to help her fill this form. So what do you think? Right? I know this class is bumetanide, is a loop diuretic. So what is the most common side effect of a loop diuretic here? Are you looking for something you always know? Say, oh, because it's hypokalemia, because it's diuretic? Well, I never give you that, right? That is what most people think, right? So furosemide is the same thing, bumetanide. They cause the same thing. But one thing you should know, they are sulfur drugs. They are all sulfur drugs, and sulfur drugs causes photosensitivity. So this one go here. This is one medication you have to know. This alone has a bunch of cardiopharmacology. It's a sulfur drug because photosensitivity, right? Then the pill, for C, no pill. The first name does not matter, right? It's a pill. A pill are what? PRI. What is the most common side? And what group of medications are they? They are what? ACE inhibitor, right? And the most common side effect of ACE inhibitor is angioedema. What is losartan? What is losartan? What do you think? Losartan is an ARB. ARB is angiotensin receptor blocker. It does the same thing as ACE inhibitor, but they don't cause angioedema and cough. So that's why this one go here like that, losartan. And now you left with this. You can figure out isosorbide. This is test taking strategy. It's a nitrate. Nitrate, what does nitrate do? It pulls fluid into your vein. So if this is your vein, I pull fluid in your vein, in your legs. If fluid stay in your leg, it's going to cause edema. It will be leaking. Your face will look red. So nitrate causes any venodilator causes flushing. So venodilator causes flushing. And we all know spironolactone has effect on steroids. It displaces steroids from and estrogen and testosterone from the blood and make them more available. So don't only know about hyperkalemia. One of the side effects of spironolactone, when you give it to a patient, check them, they will be growing boobs if it's a male. So gynecomastia is another big side effect of that. One question, bunch of cardiac farm. A nurse is providing care for a client in the emergency department who presents with septic shock. Which prescription the nurse should prioritize? Break down the question. I underline prioritization. I need to prioritize. It means who do you want to see first? Who need a follow-up? Who need immediate intervention? Just group them, right? And the nurse is taking care of the patient, the buzzword, right? Septic shock. Try to spend time analyzing the question before you proceed to answer. Okay, so which prescription you need? I have given you two things, septic shock and prioritized. septic shock, and prioritized? The best way to answer this question is to know the definition of septic shock. Do you need to know about septic? No. It's a shock. It's a kind of shock. Therefore, what is the definition of shock? Shock is hypoperfusion. What is hypoperfusion? That means your blood is not enough. Your tissues are not getting blood. They're not getting things that they need. So your blood pressure probably is low. So they are in shock because the tissue are not getting flow. Make them flow. Make the blood flow to them. Which of these options is going to make the flow better? It will affect the hypoperfusion. That is all, guys. That is all. Definition of shock is hypoperfusion. But hypoperfusion, which of these is going to allow blood to go faster? Vasoconstriction is going to constrict you and make your blood pressure go to specific areas. If you keep them supine, yeah, it will not decrease their blood pressure low. I need to give you fluid. Fluid, fluid, fluid. Antibiotic, you have to get a culture before that. So, once again, think about the question and see how it relates to the answers being given. Okay. And this one, I just want to give you, it's a bonus. I give you all the pharmacology related to Parkinson disease. A novice nurse has attended staff education on Parkinson disease. Which of the following prescriptions the nurse should recognize as possible medications for the management of Parkinson disease? If you know Parkinson disease, this is easy. All I'm asking you, what or which of these medications can be used to manage Parkinson? But this is Parkinson disease, okay? There's three classes of medication. Three classes of medication, right? There is a dopamine agonist. That means they dash things like dopamine, right? There is medication that will increase dopamine by stopping breakdown of dopamine. There is medication that are anticholinergic. They decrease acetylcholine. So if you study in Parkinson and you get to the pharmacology, I have given you everything. I can make these 2-minute videos on this, and you have everything you need to know about Parkinson drugs. There's agonists that look like dopamine. There's those that will prevent dopamine from being broken down. And there's an anticholinergic that block acetylcholine and allow dopamine to go up. Three things. Put them into the group and see if each of all of them meet the criteria. I'll give you the answer. I told you the class of medication. These are all medications that I've given you. See if all of them satisfy. Let's take the first one. Okay. Do you see anything that is an agonist? And it's from mepizole. It's an agonist. And apomorphine. These are agonist dopamine. Which one is anticholinergic? Test taking strategy, right? Anticholinergic is going to speed your heart rate up. What medication do we use to speed your heart rate up? It's atropine, right? I see atropine here. Then if you don't know this, look at it. Benztropine. Benztropine is the same thing as atropine. It has the same last name. They're from the same place. So these are anticholinergic. They can also be used for dopamine. Then we left with those that will prevent breakdown of what? Dopamine. They increase dopamine by preventing it from breaking down. Do you recognize this medication? Look at it. Rasagiline. What do you think it belongs to? Who take the NCLEX to say, hey, I saw some medication I've never seen before. Do you see that? Rasagiline. Can you tell me if you recognize something like that? This is, and what does it sound like? What does it look like? Does it have a surname medication you've seen before? It prevents dopamine from being broken down. It's not insulin. It look like that. Celergilen. You see, it look like the same as that. Celergilen. It's not for myasthenia gravis. It looks the same as celergiline. It's an MAOI. So MOIs will increase your dopamine. So you see the gillen, and it's the same thing. So these are medication that will also increase your dopamine. Who recognize H? The last one. What do you think? What medication is that? Look at the last name. Fluphenazine. What is fluphenazine? What is fluphenazine? It's a typical antipsychotic. Do you think we can use it in Parkinson patient? Can we use it in Parkinson patient? Thinking. Fluphenazine is an antipsychotic. It's a first generation antipsychotic. The function of the first generation antipsychotic is to block dopamine. They block dopamine. Therefore, we cannot use this because it's going to block dopamine and it's going to make things worse. Therefore, it's not a good answer. So these are your answers for all medication you can use for Parkinson. So I've given it to you. Next time when you see them, don't fall for them. Okay. Okay, so now, based on the clinical data, which of the following the nurse should recognize is consistent with the disease process? So click on the clinical data. And this is the case. This is the case form. I didn't want to give you too many cases. I give you one, back you'll have make the 6 case. I did not give you enough information to give you the clue, but I give you enough to be able to make a diagnosis. When you're taking the NCLEX, try to make a diagnosis after you read the case. What do you see? 42-year-old male with depression, bad weight, poor memory, jerky movement of the limbs and fingers. His father died of similar condition in which the symptoms progressively worsen, proceeding to dementia until the death at the age of 50. Short. No medication. He has no allergies. No bladder problem, no bowel issue, and no weakness. Can you figure out what I'm trying to say? These are his vitals. And the board will give you a bunch of normal. It's designed to confuse you and say, what is all this normal? I'm trying to make a diagnosis. I've given you enough. And then I will throw a bunch of normal stuff and abnormal. Alert oriented times 3. His people are equal reactive to light. His face is midline. His S1, S2 is present. Long, clear bilaterally. Have you seen this before? Yeah, that's the way it is supposed to be. Abdomen soft, non-tender, non-distended. Feet are warm, pulses, +2, right? Should it be +2, right? They will give you a bunch of normal stuff. Inattentive, poor. Then I give you abnormal stuff. He has inattention. He has poor concentration without memory loss. He's restless. He has frequent involuntary jerky movement. He has depressed mood and no focal neurological deficit. All the labs are normal. You get an MRI and CT scan. There's what? Degeneration in the basal ganglion, and his brain is very small. What have I given you? I've given you enough information. At the same time, I try to hide a bunch of things. I put some normal things here. If you know this, it will just pop up like a candy. Okay, that's good. But this is something I've given you typical questions you will see. And if you make a diagnosis, the rest is easy. 42-year-old, a young person with depression, some memory problem, a jerky movement is the same thing is found in the family who die at the age of 50. You're talking to him, he has poor memory, inattention, a jerky movement, he has mood depression, and there is an atrophy of the brain with the loss of basal ganglia. Can you figure out what he has? Then what are you going to do? They said select or apply. Based on the clinical data, which of the following the nurse should recognize is consistent with the disease process? If you know what it is it consistent with autosomal dominant disease? You got to select. Select or apply. If you know it, if you are not sure, just leave it. Pick those you're confident. Onset occurs between the age of 30 to 50. You can progress and die 10 years later, and there's no specific treatment. The genetic counseling is regarding to future offspring so that they don't have the same babies. They have emotional outbursts. Do they have psychotic overtone? Are they at risk of fall? Do they need a prescription for tetrabenazine? Do they need care by interdisciplinary team? Do the gene has CG repeat greater than 40? And they are loss of GABA-energic neurons. That means inhibitory neurons. If you know what it is, you can ace this question. So what do you think? What do you guys think? I see the answers there. This patient has a classic symptoms of Huntington disease. Instead of giving you a 6 case study, I give you all the content you should know about that disease so that when they give you a case, you can use this to answer the question. I can tell you it's autosomal dominant. That means every generation is supposed to have it. That's why his father have it, right? And based on the kid age, you can see onset, he's 40 years old. So that one, this is good. As he progresses, you're going to die. His father died. You saw it in the case. His father died when he was 50. So that's consistent with that. You have 15 to 20 years to live. There is no specific treatment for that. They will need genetic counseling, right? For future offspring, so that you know your baby that you're going to get born is going to have Huntington disease. They have psychotic overtone and emotional outbursts because of the depression they undergo through. And then you can explain why they are risk of fall. They have jerky movement, coriform. I intentionally left that one out in the case. If I put coriform, you can figure out easily. I said jerky movement. I can change it. I can put tick, right? TIC, tick movement. Watch for those kind of synonyms that the board use. You know the thing, but they change it. You say, I can't find the answer. It's there. So this patient has a risk of fall. We use tetrabenazine. This is the pharmacology. It's for treating symptoms of hyperkinetic. So that's what we use. And this one, I'm just giving you the content for that disease. You see. And then they need interdisciplinary team. You need occupational therapy, physical therapy. They need swallowing steady because the muscles of the neck will be affected. It's a neural problem, right? And this is the problem. They have repeat of CG. This is glutamine. And the reason why they keep on moving, because these neurons are designed to stop you from moving, GABA neurons. And they have destruction of them in the basal ganglia. This is Huntington disease, guys. This is it. That's the content I've given you. Everything you need to know. If you take a picture of it, yeah, that is Huntington disease. Anybody have questions? So that one is just to give you bonus, right? Content bonus. Now, prioritization, of course. And let's provide care for several clients with congestive heart failure exacerbation. Which client the nurse should prioritize? All of them have congestive heart failure. Look at them. You have to be sharp. If you know what be sharp is, you check out damn thinkers. That means when you're picking an answer, you want to know if the patient, the answer you're choosing is going to save the patient. You have 1 second. Is it a breathing problem, electrolyte shock, sepsis, airway? And you have 1 second. Who do you want to give it to? They all have bad problem. BMP of 400, class 2 leg edema, increasing oxygen demand, and they've gained weight 4 pounds in 2 days. Test taking strategy. And I told you they are in CHF. Therefore, when picking an answer related to CHF, don't pick expected finding. If you pick an expected finding, then you go wrong. So which one is an expected finding? If it's an expected finding, then don't pick that answer. So who has expected finding? And what is your answer? So who do you want to see first? Who do you want to prioritize? Don't pick an expected finding. Pick a prioritized question, answer choice, one that you have no time, 1 second to take care of. So think about the answer choice before. And the way to answer the question, like I'm trying to explain it to you, they all have CHF. And then expected finding means the definition of HCHF. Gaining 4 pounds in 2 days, that means they've gained more than 3 pounds in 2 days. That is the definition of CHF. You should not pick D because it's the definition of CHF. If you gain 4 pounds more in 2 days, you have CHF. So this is a wrong answer. It's not a prioritized information. Once again, if you gain 4 pounds in 2 days, that is the definition of CHF. Therefore, it's not something the nurse should worry about because the question say the patient is in CHF. BMP greater than 100 is the definition of CHF. Whether you have 400 BMP or 2 million BMP, I don't care. It's not a priority. You have to be sharp. If you have class 2 leg edema, it's because you've gained weight. It's an expected finding for CHF. When you have oxygen demand, I don't expect that. That means you're telling me you're dying. But when you have weight gain, you have leg edema, your BNP is going up, I expect that when you have CHF. This is what you do with prioritization. Something that is not common with that problem. It's not consistent. I want you to think about a question in a pathophysiological way. There's no formula for prioritization. Think about it. If you have these 4 people, you go to each room, somebody with leg edema will be just sitting there. Somebody with weight gain will be just sitting there. Somebody with BMP of 400 will do the same thing. Somebody will be with increasing oxygen demand. You will see from their face. They say, I'm dying. I need oxygen. My SAT is dropping. If they can talk to you, they will tell you. So don't pick deep. It's all designed to trap you so that you can think about the answer choice you're picking. This is how you do prioritization. And that's how I do my prioritization. So if you need more, like I said, you check adapting right. This is the same thing. Don't get trapped with these questions. And next, provide care for a client with new diagnosis of Crohn's disease, underlying Crohn's disease, which finding the nurse recognize is not consistent. The word is not consistent. So how do you answer this so that you don't get confused, get trapped? It's unexpected or you don't expect it. This is what I call it, bi-directional thinking. Find what Crohn's disease is and see what is you should expect under Crohn's disease. I will tell you, it's a tumor in adrenal gland that secretes aldosterone. What does aldosterone do? What is its function? The function of aldosterone is what? What is the function? The main function of aldosterone is to hold on to water by holding on to sodium. So it's definitely increasing your sodium. And if it's holding on to your sodium, every time your sodium go in one direction, it's going to get rid of your potassium. This is why we have something we call adactone. Adactone is spironolactone. It blocks aldosterone. So aldosterone will increase your sodium and decrease your potassium. Now, it's holding onto your water, and then your sodium is going up, decreasing your potassium. When your water goes up, you get headache, edema. When your sodium go up, you get hypertension. Do you have to memorize this? No. You can. You see, I've deduced the function of that thing. Therefore, I should expect what? Headache, hypertension, hyperkalemia, and hypernatremia and hypokalemia. Now, the last one, this is the advanced level. Your potassium is low, right? Hypokalemia. Your body will try to compensate for the hypokalemia. It's going to potassium. There's a lot of potassium inside your cell. So your body will push potassium outside the cell to increase your potassium. In the process, it's going to push H plus ion. So you're losing acid. It will make you lose acid. It puts it inside the cell because they are all the same charges. I don't have to go into detail about pharmacology and chemistry, but if you look at the periodic table one, yeah, this is what happened. Because if you gain potassium, you're going to lose H plus. If you're losing H plus, you are not going to be metabolic acidosis. You're going to be metabolic alkalosis. This is how I can explain to you why this is wrong. So this is wrong. We should expect headache. We don't expect hyponatremia. We should expect hypokalemia and hypertension. So your right answer are A and C. If you know only one, I want you to pick it and move. Don't guess. Don't do anything. Just don't over-select for your test. So I explained to you everything. So I don't expect this. No, I don't expect that. So don't over-select, okay? It's the same things, design, the same question. And next, attended start application on what? Chronic obstructive pulmonary disease, right? Which finding the nurse recognize is consistent with emphysema when caring for a client with what? This condition. So which finding? So this should say finding, right? I got to edit this. But what I'm saying is patient has COPD. When you examine them, you went to a training, they told you about COPD, and you're taking care of a patient with emphysema. What are you going to see? Which of this would you see in emphysema? Remember what your board is going to confuse you with. Is either emphysema or what? Bronchitis. So which one is emphysema and which one is bronchitis? The question say emphysema. So don't get trapped. Pick answer choice that is consistent with emphysema. Look at it. Write down emphysema on your board, your whiteboard. Write it down. Say emphysema, bronchitis. If you know bronchitis, write the answer choice bronchitis and then eliminate the bronchitis question. If you know emphysema, write it. But the pathophysiology for bronchitis is mostly recurrent infection leading to a bunch of secretion. And therefore, if you have secretion, you're going to cough. That's all. I have a single video in my channel about the difference between this. But this is the key thing. Excessive secretion leading to infection, and therefore you cough. That is bronchitis. Emphysema, no. The lung is being trapped. So they have big lung, okay, big lung, and barrel chest. And they have bullae, which can pop open. It's like a balloon. So think about them as balloon. Just by that, I see cough, I take it away. Even if you don't know what half cough means, it's used to clear secretion in bronchitis. I see morning cough, I take it away. I see recurrent lung infection, I take it away. You see what I've done? I've given you the answer choice. Trapping, because I told you, is like a balloon. And then the air trapping go into a bullae. It form like diverticulum of your lung. That's the way I can explain it to you. And these diverticulum can perforate. When they perforate, they become pneumothorax. Easy way to master bronchitis and emphysema. You see what I told you? I tried to explain, use analogy that you can get it easily. So we are not coughing, we're trapping the air. If we trap the air, we form diverticulum of the lung, and these diverticulum always perforate. So this is what you got. Okay. Now, a dialysis nurse provide care for a client with end-stage renal disease receiving dialysis via atriovenous fistula, AV fistula. The client, you should say, the client reports sudden onset of what? Nausea. These are bad words, like I've told you. Bad words, right? Sudden onset of what? Nausea, headache, feeling of restlessness. Arrange the action the nurse should take in order of priority, right? So what does she do? Nausea, headache, restlessness, and arrange these in the order of priority. And I got to edit the question, but the point I want to emphasize is nausea, headache, feeling of restlessness when you get in dialysis. You can arrange it, but I just want to show you some content you should expect your board can ask you. Do you know what is going on with this patient? It's an end-stage renal disease. He's getting dialysis. All of a sudden, I have nausea, I have headache, and I feel restless. What is the problem? What do you think is the key aspect of it? Disequilibrium syndrome, right? Nausea, headache, and the feeling of restlessness. That is disequilibrium. Then to answer this question efficiently, when this usually doesn't get presented that way, but the best way to think about it, disequilibrium is an ICP issue. Look at the signs and symptoms. Patient is behaving like they have ICP problem. Every time you see disequilibrium, treat them like ICP patient. So what is the first thing you would do? Patient is having disequilibrium. So what would you do? What would you do? What's the first thing? So how do you treat this patient? What do you want to do? What do you want to do? I can tell you, I always say it, when you have given somebody something and they're making them sick, stop the poison. Stop the poison. So we stop the poison. And then we let the doctor know. After we let the doctor know, we raise the bed up and then prepare to give the hypotonic saline and then low stimuli. So this is the way, if you see a multiple choice question, don't call the doctor, don't do anything. First thing, stop the dialysis and then notify the doctor, raise their head, prepare to give them hypotonic saline and then low stimuli as much as possible. So that's the way you can do that. So that's the first thing, like I explained, it, ICP issue. We're almost done. Then I can let you guys go. A registered nurse, a practical, a licensed practical nurse, and unlicensed assisted personnel are caring for a client in the surgical unit, which tasks the RN can safely delegate to a UAP. Okay, delegation 101. Keyword. I don't know. There's so many things you can, everybody does their delegation differently. There's so many tasks that they can do. But I try to say, don't do that. Don't overwhelm yourself. Tell yourself, UAP will help with the ADRs and anything that does not require thinking. Anything for your test. It doesn't mean they don't think, but the answer choice sound like they are not thinking, right? It doesn't mean when they work, they don't think. They think. For your test, think about it that way. ADR. So I'm assisting you walking, that's all. And anything that does not require thinking. When you tell them to go check your vitals, they don't have to do any calculation, nothing. Go and take the IV, the blood pressure cuff, slap it there, and they take the blood pressure. The machine itself take the thing and they record it. So what is over there, that does not require thinking. That they taking care of. What is over there? Then the LPN, I call it MMR most. If you want to know more, just check out that thing because you see MMR most. What it means is the most medication they can give, they monitor, they reinforce, take care of stomach, tube feed, and then special test. That's all. You say, hey, what about this? What about this? Then you make the list long. I bet you your test will always use these buzzwords, I call them reinforce. You see it in every test. You go take a Q bank, you see it there. Reinforce, right? They use these buzzwords. Educate, right? Educate always belong to the RN, right? Reinforce belong to the LPN, right? They monitor, and if there's anything that's a monitor, always give it to the LPN, right? The teaching and other things. So for this one, they cannot do anything with stomach, but they can weigh a patient. They don't have to think about anything. They can watch them. They don't do anything. I'm sitting there watching TV. I'm looking at the patient eat. It's not a problem. They can check the patient blood glucose before a year. It's not an assessment. It's a vital, right? So they can do that. So BCD is all functions of the UAP. They can do that without any problem. But they cannot reinforce teaching, they cannot educate, and they cannot do stomach stuff. So, and the last question, just to test your mind, a nurse provide care for a client on pitavastatin. You say, hey, I've never heard about this drug before. No, trust me, you heard it multiple times. Look at the last name. You know what it is. Complain of muscle cramp. I give you some idea to think about it. He's taking this and he has muscle cramp. What do you think this is it? Go for the last name, Peter Vastin. Peter Vastatin, right? It's a Peter Vastatin. What do you think it is? You know what it is. Which laboratory value require immediate follow-up? Which one do you think? Hey, you got to act fast. If you don't, patient die. LDL elevated, HDL elevated, creatinine elevated, creatinine kinase elevated. In the muscle cramp, the worst thing that can be is rhabdomyolysis. Which of this indicate rhabdomyolysis? If your LDL is elevated, it means your cholesterol is not controlled, control problem, right? If your HDL is elevated, this is a good thing. That means we have control. If your creatinine is elevated, we have renal failure. How do you develop renal failure? It's because you have rhabdomyolysis. And the evidence of tissue damage is creatinine kinase, not just the creatinine, that's the kidney. The kinase is the enzyme on the protein for the muscle. Therefore, this is your right answer. This is adapting class, chaperoning. Like I said, if you want to join our crash course, this is where to get it from. It's me lecturing that I can lecture you. We do a bunch of questions. It's 10 days, sometimes 11 days, sometimes I push it to 2 weeks, depending on how the class is going. You get access to the on demand. And then 85 questions like I give you. But take care of yourself. I hope you learned something. Be good and good luck. Best of luck.